bilateral lateral lobes were enlarged, small median lobe, and rest normal. Urethra was normal. So plan is thulium laser enucleation of prostate by Dr. Arupnath sir. Arupnath sir is one of the leading surgeons and he is specially trained in laser and laparoscopic work. So he did his MCH from BJ Medical College and Civil Hospital, Ahmedabad. He has performed more than 15,000 surgeries all around in Northeast, and he has also performed 150 watt thulium laser prostatectomy and zero ischemia laparoscopic thulium laser partial nephrectomies. So he has been invited to many live operative workshops across country like Kolkata, Ranchi, Bhubaneswar, and he has been regularly holding hands-on training camps and training many urologists from India abroad for laser surgeries. He has special interest in thulium laser enucleation of prostate, and so he'll be presenting and teaching us how to do thulium laser enucleation of prostate. So over to sir. Sir,
okay.
Hello, can you hear me, Anshuman? Hello? Anybody on mic? Hello? Ha. So in second OT, we are starting with RIRS. Can you hear me, Anshuman? So it's the first case in OT2, Siam OT. So we'll be doing all Siam cases in that OT. So 40-year-old female with left lumbar region pain. No fever, no vomiting. So stenting was done for RIRS on 4/12/22. No comorbidities.
It's okay.
All blood works were within normal range. There is a middle calyceal stone, and CT and IVP is done. The surgeon is Dr. Debajit Bes. So he did his MBBS and MS from Guwahati Medical College, MCH from Guwahati Medical College, and he has done more than his area of interest is minimal accessive surgery, and he is specially trained in RIRS, PCN and laparoscopic surgery. Attended many conferences and multiple publications in national and international journals. He has special interest in lasers in urology. So he'll be doing case for RIRS.
Okay. Laser fiber.
Hello. Anshuman, who is the chairpersons? Chairpersons को वो कर दो ना, मतलब introduce कर, so that they can discuss the case with sir directly.
Okay. Yeah. Good morning.
Good morning, sir.
Good morning. So we are almost ready to go ahead with the first case. 76 gram prostate. Patient was on, as Dr. Padmakar has already explained about the case. So we did initial cystoscopy. This is a suprapubic catheter, and there was multiple, you can see trabeculation is there, and mucosal polyp kind of thing, all this, and the gland is mostly a bilobar enlargement with little median lobe with engorgement is there. So this is the Veru, and you can see that the enlargement, the glandular enlargement has not gone beyond Veru for long distance on the left side, but the right side you can see that it has come to up to this level, and this is the sphincter. So we'll be quite away from the sphincter. Now, hello, yes. Yeah, Dr. Ranbir, good morning. Yes. This is lower tract set from Karl Storz, and 26 French continuous irrigating iglesia sheet with 30-degree telescope from 5 mm 30-degree telescope from Karl Storz, and the endovision system from Olympus, and the fiber is a intercardia thulium fiber laser, 60-watt laser, and I am using a 550 micron fiber. You can see this is the 550 micron fiber, and the setting is 4 joule 13.8 hertz. This is total 55 watt I am using for enucleation, and for hemostasis I am using 0.1 joule 300 hertz. So that is 30 watt. So earlier for enucleation of prostate either by holmium, thulium or thulium fiber, everybody confined to energy level of up to 2 joule, maximum 2.5. So first time in the month of September when I demonstrated Thuflep at Preeti Hospital, Hyderabad, that is the first time we used more than 2.5 joule. We demonstrated, rather we were using at our place. We demonstrated that with high power, like more than 3.5 joule, you can get even a similar effect like holmium laser, which you can say is a blasting effect, and it separates the tissue. So there will be not much of tearing because we will not touch the tissue, as opposed to a thulium YAG laser where we have to touch the tissue and you get some tearing. Now my plan is whether the audience wants to see a unilobar technique, bilobar or trilobar. So I am regularly nowadays practicing unilobar technique, and we have developed a unidirectional en bloc kind of technique at our place, and I have demonstrated that even at the Preeti Hospital, and everybody were very happy to see the easier version of en bloc enucleation. But for the beginner or those who are planning to do a laser enucleation or who are starting, a 3-lobe or 2-lobe technique will be easier for them to follow. So if you wish, I will go for a trilobar technique by making incision. This is 5 o'clock, then I will make an incision at 7 o'clock here and enucleate the median lobe first. After that I will go, or if you want, I can make single incision at 5 o'clock and enucleate the median lobe with the right lobe and left lobe from that 5 o'clock position. So that way it becomes a 2-lobar technique, and if I just go from here, that will be unilobar. Anyway, I will first mark or do the mucosal release incision. Till then, you people guide me which technique you wish to see. So you want me to go with a 2-lobar or 3-lobar technique? Okay then I'll go with a 3-lobar technique, which will be much easier for the public to follow, and those who is new to laser enucleation of prostate. But otherwise, in 100% of cases, the smaller, bigger, whatever the size, we are doing en bloc resection at our place, en bloc enucleation, and this will be a anatomic enucleation of prostate. So we'll hollow out the transitional zone, that is the adenoma, from the capsule, surgical capsule. So first we'll make the transverse incision. Start laser. Start. Okay. You can see that I am starting just proximal to the verumontanum. So I'll move the laser fiber transversely here. Then at this point you will definitely encounter some amount of bleeding, but that gradually will come down. Now I will complete the encircling incision. You can say it a mucosal release. Okay. Here, if I do a mechanical enucleation like this, I can do a mechanical in this point and enter into the capsule and then completely enucleate the lobe. Yesterday we were discussing during the deliberations that if I completely enucleate the apical lobe, there will be chances of transient incontinence, which definitely will come down after 3 weeks. So if I make a mucosal incision here, there will be less traction while doing the enucleation later. So there will be less chance of incontinence, has been proved in many literatures. So this is the point where I will mark at 12 o'clock. Then I will join both this incision. You can see that my hand is moving the way the laser fiber is moving. So my right hand, with which I am holding the working element, now gradually moving laterally then upwards. Yes. Now you can see the orientation. Yes. Now again I will come down. Good morning. Dr. Nitesh. Hi. Yeah, you can go. That is the reason why you need to come down and see where the sphincter is. The sphincter is quite away. So sometimes the glandular orientation is like it comes quite beyond the verumontanum. In that case, you may come down distal to the verumontanum also. Definitely. That is true. So in this side, if you see that gland has come little distal to the verumontanum, this side, in the right side. So I will complete the incision in this side.
Drip set. So you can use it for irrigation. I will irrigate the fluid by this 50 ml syringe. So the assistant will also take part with this process, because if we use this handheld irrigation system, the irrigation control will be with us and we can manipulate the irrigation. Sometimes we need to stop the irrigation, sometimes we need to flush slightly harder, so we can control. So it is a very useful process of irrigating system. So I have already put the guide wire here. You can see in the picture, and it will assess it. So it was it little bit difficult to put the guide wire, as she had a cystocele also. Yeah, you can see the CM picture. CM. You can see the CM picture, sir. यहाँ पे थोड़ा सा focus in the CM picture. थोड़ा सा पानी ले लेना. Can you see the CM picture, sir? CM you put here. यहाँ पे लगे हो ना CM हो जाएगा. So I have put the guide wire there, sir, and there is a little difficult in putting the guide wire because she had a large cystocele. यहाँ पे pelvis में यहाँ पे. So sir, we have to push the cystocele upward to see the ureteric orifice. So now we are ready to put the ureteral access sheet. So I am using 10 by 12 Airtel SS sheet because the patient was stented 2 weeks back. So I think the ureter will be petulous and there will be spacious ureter for me. But when I go for in case where the patient is not stented, when I using the this ureteroscope P7, then I can go for 9.5 by 11.5. So but the patient is stented, so we are going for 10 by 12, and it will give us a good irrigation flow, better visualization and good outflow, and thereby reducing the intrapelvic pressure. So niche aa jao. So I am putting the aortic access seat slowly. So during putting the aortic access seat niche, okay, sure. So I am putting.
This is the plan. See,
Siam picture. No, niche karo to. Bas. Sir, can you see the picture? Zoom out, no? You can see the, sir?
Your picture is coming but in partial. It's zoom in, so make it zoom out first.
Zoom out.
40 gram.
Can you see the same picture? No, none, sir.
40 gram.
Same. Yeah.
It's not like 40, but maybe 40 plus.
You can see?
Better orientation, no?
Sir, can you zoom out the picture? Same picture. It is very important step actually.
So when you come like this, na, so you make the laser fiber active and then come out like you do in BIU. You just come out, not like if you activate the laser fiber and do this, then there may be some sharing like
क्या
this.
करूँ?
So you move out.
एक्चुअली इसको पकड़ना चाहिए, ये भी इसे बोलना चाहिए, इसको कैसे पकड़ता है ना, ऐसे, क्योंकि otherwise if you push here, no, it will come out, the obturator will come out. No, fix करो बस.
It doesn't make any difference. So at the blood and
नहीं,
also
ये
like in
देने के बाद चला जाने से
you
कोई
will get
दिक्कत
some
नहीं था.
bleeding. So don't worry for that because there are always
स्टोन हाँ वेट कर लेते हैं.
but you need to make the anesthesis complete before you leave. Okay.
Shift the audio to only one place.
This is 41 or 42. Hello, sir. Am I? Sir, can you see the same picture, sir? Yes. Okay, sir. And I want to show how you hold the aortic access sheet actually, because the aortic access sheet has two parts, no, sir. This is obturator part and this is the sheet. So when you hold the aortic access sheet, you have to hold this part so that the obturator doesn't slip. Though you have to hold the both part actually. You have to fix the obturator and the sheet also, and gradually with the left hand you have to push it there.
This is the adenoma, this is the capsule. So this is the point which we need
Yeah, you can show here, no? You can show here, camera person.
touching the gland.
इसमें करो ना.
Yeah, as a leverage.
Yeah, this thing.
Yes. No. Mechanical.
Can you see, sir, my hand?
To stretch out the capsule. To stretch out the tissue which is getting attached from the capsule to the.
Sir, please see my right hand and my left hand and the angulation towards the ureter. So if we put this sheet like this way, then it will be angulate with the ureteric orifice, and the ureter, the guide wire will be kink, and we cannot negotiate Okay, sir. And during when we insert the aortic access sheet, we have to hold this part is obturator and this part is sheet, and we have to hold both part to fix, because otherwise, if you hold only the sheet part, the obturator part will may come out and it may injure the ureter or ureteric orifice. So, sir, I am going inside. I am fixing this by right hand, this obturator and sheet, and with the left hand gradually under CRM guidance, I am putting the aortic access sheet. So I will put the aortic access sheet up to the upper ureter because it is a 45 centimeter okay, nice, no problem. It is a 45 centimeter length. So definitely more part will be come out from the body, outside the body. So now I will start inside the flexible scope. Okay, you have to fix the sheet, and both guide wire and the obturator will come up. Sometimes in the newcomer, when we are starting the RRS process, then we may use the guide wire as a guide to negotiate the flexible ureteroscope to the kidney, but I am prefer to go under vision.
After the
Okay.
X3 will shift the audio there.
Yeah. About to finish? Yeah. Okay. Yeah. Light cable?
Light cable,
नहीं है,
connector.
कनेक्टर इस तरह Yeah. Okay. तरफ है क्या? दिखा दो, है क्या? नहीं हुआ क्या? लग गया. एक्सटेंशन ट्यूब, ट्रॉली इस तरफ लेके आओ, है ना? ट्रॉली इस तरफ लेके आओ, ना, एकदम पास लेके आओ, जो नजदीक लेके आओ. हाँ हाँ, आप ये ट्यूब ना यहाँ पे डाल लो, यहाँ पे.
Hello? Yes. Yeah. What do you do? Hello?
हाँ. Hello, sir.
Hello, Devajit.
Yes, sir. I'm here, sir.
Please show the pen movement.
Yes, sir. This is
And CRP, where is your access sheet, please?
okay, sir. Can you shape the CM? So okay. So you can see in the CM ऊपर थोड़ा सा ऊपर, धीरे हाँ, और थोड़ा ऊपर. It is in the upper ureter. The ideal position is 4 to 5 centimeter below the PUJ, because if you extend more towards the extend more, picture is not clear. Can you see? You are seeing, so you are seeing the endovision or what, sir? Hello, sir. P7 scope I am using. So Olympus. So Olympus scope, it has 3 part. This is the deflecting part. So the deflection is when we push down, it goes down. When we put up, then it goes up. It is a logic type of scope. So this scope is around 7.95 French. So I am using sheet of 10 by 12. So it's very easy for us. And the movement of the scope is by 2 hand. So my left hand will fix the I'll fix the sheet by this 2 finger, middle and ring finger, and I'll the flexible scope I'll negotiate by this this index finger and thumb, and by the left hand. And also by the left hand you can do some some 20-degree movement of the shaft you can have. And by the right hand, for when we are going for right side kidney stone, our palm should be palm out movement, and when we left side kidney stone we are operating, then our hand will be palm in movement. And the ureteroscope you have to hold finger palm grip method, because if you directly keep the scope in with finger, it will be very fatigue to the surgeon, and with palm method also it will be difficult to manipulate the ureteroscope. So finger palm grip is ideal. And by right hand, the lever movement, up and down movement, palm in and out movement, these two movements are from the right hand. And from the left hand, I will fix the ureter access sheet and will up and push the ureteroscope towards the kidney or outside the kidney, like that movement. To and fro movement will be there, and 20-degree lateral movement of the shaft we can see. Okay, so I'm going to the kidney now. So I'll first air free the pipe, irrigation pipe. So put some water. Are you audible, sir? Hello, sir. Sir, yes, sir. I usually avoid ureteroscopy, semi-rigid ureteroscopy, sir, because in case of some doubt, when we see some ureteric stone, or in case when we are not, we have difficulty in putting the ureteral access, then only we do ureteroscopy, semi-rigid ureteroscopy. Otherwise, in my practice, when we do semi-rigid ureteroscopy, it will have some bleeding, and the vision may impair during flexible scopy. So, okay, yeah. I'll now enter. Okay, just push. Okay.
Yes, yes.
You're seeing the endovision now. So, okay.
We develop the plan between the adenoma and the capsule. Then we
So it is 10 by 12, sir. So in this part, I want to also push water. I want to show that if you go directly, will hit the ureteric wall. So we always go inside, and little bit we have to pull out the ureteric access sheet, and then we have to negotiate in the ureter. So this is the movement we should do. Yeah, this is.
superior and inferior inoculation plan.
Yeah, this is a pelvic stone. We have first we have seen the stone, and these are the, this is upper calyx.
Below will guide you.
Okay, this is upper calyx.
Needs to
Okay,
be superficial.
this is the middle one.
To meet them both,
Okay,
both
and we have to inspect. Okay, this, in the, this is actually part of the stone. Okay, this is the middle, and it is a lower calyx. Okay, we can see. Okay, can you have the this laser? Laser.
Okay. Hello.
Clear, no? Okay.
Yeah. So, yeah, Sambhavu sir, we could see. I think I could. I enucleated the median lobe, and then push it to the bladder. Then I developed the plan in the peri-veru area. Then I started enucleating up to 3 o'clock position. Okay, then I developed the plan at 12 o'clock, 12 o'clock incision from the level of bladder neck up to the level of the mucosal incision we have already made. Then gradually I undermine both the plan from above and below, and I have made somewhere at around 3 o'clock. So can you feel that this is looking like something like holmium? So because I am using a 4 joule energy, so here I need not have to touch the tissue, which is the apprehension of the people that thulium causes, thulium YAG rather, thulium YAG used to cause some charring because you need to touch the tissue because being the continuous wave laser. But here in thulium fiber, we are not touching even, we are operating from a distance 2 to 3 millimeter away from the tissue, and you can see that I am not using, not touching the tissue, and it is splitting the tissue as in holmium. Left side of the lobe.
So that for that you have created first the plane at 12 o'clock.
12 because for enucleating the median lobe, I have already made the incision at 5 and 7 o'clock. Then I undermine both the incision little laterally, and then make a trough bigger enough, and then I make the incision at 12 o'clock when I do a lobar technique like unilobar or bilobar. After that, you need to come down from that incision at 12 o'clock to laterally. If you are preparing on the left side, you come on the left side. If you are preparing on the right side, you come on the right side accordingly. And then you come down to the level of Bheru and develop the plan laterally from the level of Bheru Mantanam, on which side you are planning. And then, yes, then you try to meet both the incision at the level of 3 o'clock position, or maybe at 2 o'clock position or 4 o'clock position, whatever may be the position, because you are enucleating from both from below and from above. So you have to meet both the enucleation plan laterally. Here you can see that I am using the beak of the assembly that TUR sheet to stress out the tissue, so that I get the stretching tissue coming from the capsule to the adenoma, and then cut it with the laser fiber, active laser fiber. So in mechanical enucleation of prostate, what you do, you do not cut it with the energy. You coagulate later while doing a mechanical enucleation by either monopolar or bipolar. But with laser, you can see that this tissue, I need to cut it here. You can see. So it has come out so beautifully.
Like holmium, in fact.
Yes, sir.
And except that the plane of the adenoma,
Yes, sir.
holmium is more clear than that's what we are seeing here. Right? And there is, of course, there is less sharing
Yeah.
in comparative to the holmium,
Thulium. Yes. In comparison to thulium YAG, it will be less sharing, and you can appreciate the glistening capsule. This is the capsule. So what we have lifted up is the adenoma, and I have just used the assembly of the working element and the TUR sheet to lift up the adenoma, enucleated adenoma above. This is the lift up adenoma. Now here you can go. So if you ask me the basic difference of holmium laser and this thulium fiber laser is, holmium is a very robust energy, and it creates vapor bubble much stronger and bigger to thulium fiber laser. So what it will do, it will make a plan. If you do not go through the proper plan, it will make a plan, so that there are more tendency to go in a false plan, because it will make its own plan. But here, as the penetration depth is very, very low, so even if at some point you go beyond the capsule towards the tissue, or towards little deeper to the capsule also, you can anytime can fall back, and again reassess and then go in the plan. But in holmium, because it is much stronger energy, because see, I am doing at 55 watt now, but for holmium laser soft tissue, you need at least 80 to 100 watt energy. So, and that energy, it creates a very strong bubble, and that vaporization of water and collapse of the bubble, that makes the plan. So, it is so strong. If you like fire it in some tissue here, see, fiber laser is not causing mass, but if you fire the holmium here, there will be a plan, false plan. Oh, no problem. Till then, we'll go ahead with the enucleation.
Hello. Audio is shifted to OT2 RIRS. Devajit sir, you are live. Audio is live.
Hello, sir. I'm audible, sir?
Yes, sir.
Okay, sir. I'm using sir thulium fiber laser for breaking the stone. I have kept dusting mode at 0.2 and now it is 60 hertz, so around 12 watt. So I'm now only doing the dusting, and let's see if it goes everything all right. Then we'll finish it by dusting only, and otherwise if some fragments are big at last, then we'll do the popcorning thing. So I'm going from periphery to center to minimize the stone volume, so that at last we have minimum stone volume to deal with. So the center part is always difficult, sir, because it the maximum retained stone are because due to the larger fragment size, and in the center only. And one thing is that I am doing it in the pelvis, but for new people it is actually not safe. Always cornerize the stone if possible, because if you cornerize the stone, then so I want to cornerize the stone, but still the fragments are means little bit big and is not going in the upper calyx. So I am doing it, trying to smaller it, so that after that I am taking the stone to the this upper calyx if possible.
No. এটা লোড কৰিছো লোড এটা লোড সেকেন্ড লোড মই হেৰি কৰা নাই তো এন্ড ব্লক দিস ইজ ফিলড টেকনিক
Going.
one lobe then the median lobe is there somewhere.
I am using
Yes.
this thulium fiber laser, and dusting mode I am keeping it on 0.2 and 60 hertz now. You can see the fine dust are coming. This is the beauty of actually the thulium fiber laser.
You can use this also. It will be fast.
I think you can see the energy setting. Laser machine is focused.
You have to be very careful actually, because in doing in the pelvis and with the movement of the respiration, the stone is not actually fixed. So we have to keep pace with the this thing, respiratory movement actually. Yes, sir. I have asked the anesthetist, sir, to yes, it's gone. Now I am safe actually. I have asked the anesthetist, sir, to keep the tidal volume a little bit low. It is around 250, no? 250, sir. So in adult actually it requires 500 around, sir, 500. So I keep it in half, so the movement are very much low.
Whole part will come out.
So sir is doing it very beautifully, sir.
Your stress urinary incontinence. So what you could see, this little pad I just left. This tissue pad I left, no, some tissue. Yes.
पानी थोड़ा सा ज़्यादा नहीं. बस सर व्हाट आर कैसे सर हाँ हाँ हाँ
We'll be shifting audio to OT1. Audio to OT1. Sir, you are live. Sir.
Yes. Sir. Yeah, so what we did, we enucleated the median lobe. I'll show you the median lobe somewhere. This is the median lobe, small median lobe. Then this is the left lateral lobe, big left lateral lobe. We have, this is the lobe we have already enucleated. See, this is a big lateral lobe, left lateral. Now we are coming to the right lateral lobe. So this is the Verumantanam, and I have cut the apical lobe here a bit so that I do not completely enucleate the apical lobe, and there will be chances of incontinence more. So I have just left a pad of apical lobe at that place. Hello?
What is the height of the irrigation tube?
It is normal, 60 centimeter.
While detecting the adenomas, most of the places they have not gone up to the capsule. So is it purposely high with them?
Yeah.
So on basis, because we are planning to create the prostate.
Yes.
So we should start from the capsule.
Yeah, you can see on the left side, see this is whole capsule.
So that's it. Also you have almost enucleated the thing, but still capsule is not.
No, where? This is capsule, you see, left side. This is whole of capsule. This is whole of capsule. If you can appreciate, this is the glistening capsule. This is the capsule. This is the capsule. You can see that vessel behind. Yeah. Yes. So yes, nearing the apex and nearing the veru, you can use a little lower energy. So that chances of incontinence there at the level of Verumantanam and chances of postoperative dysuria at the level of bladder neck. Theoretically, yes, you can use less energy there.
The distance, the laser energy travel at 4 kilo.
See, we have discussed yesterday also that the fiber laser, the penetration depth is among the lowest. It is the lowest 0.4 millimeter, 0.1 millimeter travel in the soft tissue. So at 1 millimeter, it becomes almost zero, whereas in other laser, like in holmium, you get almost 4% energy still left at a distance of 1 millimeter. But in thulium fiber laser, at 1 millimeter distance, the energy becomes zero.
Dr. Arup,
Sir,
you have not dissected laterally, so you are going from hypoclaw to onward and lifting
Yes.
the lobe adenoma up.
yes.
So why not are you going from lateral to the median so that
You can do that. We did that in other side, in the left side. So pani to. Pani. Pressure. Okay. So this is the junction. So from here also you can go below. Yes, like this. Because this side the adenoma was not well formed at the top. So
Because from 11 o'clock laterally we go, and again from the Veru, since the gland will be, the adenoma will be in control. So lateral dissection as well as the bladder area from and the Veru to inside.
yes, yes,
Three important steps are there.
yes,
The adenoma will get in proper control.
yes, 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 definitely. So the there lies, sir, there lies the advantage of your en bloc enucleation. There you need not have to meet all those separate incision, and you need not have to enter the bladder at different places. So, just you need to enter at the level of 5 or 7 o'clock, then complete. And in our newly developed technique, unidirectional, what we do, we enter at the level of 7 o'clock position, and we finish at 5 o'clock. We do not come back and again elevate the lobe from 7 o'clock again. We just enter at 5 o'clock and
Shift the audio to OT2.
we complete it. From
Audio shift karo udhar.
Yeah.
Taponi. Taponi 0.2 and 100.
Audio is shifted to
dusting hai.
You
OT2.
require less
Sir is
time also.
almost about to finish. RIRS is almost about to finish. Sir, ek bar your line.
You can see that now.
Sir, I'm audible, sir? Yes, sir. You can see the golden dust here, sir. These are the golden dust. I have, yeah, these are the, these are the golden dust, sir. So, all are dusted. Okay, sir. And I am not, I usually don't prefer to use the, sir, basketing. I used to go for the dusting like this, and there is no actually for scope of actually, sir, to do the this basketing actually nowadays with this kind of laser, sir. And in the upper calyx you can see small fragments are there. These are actually will come out because I will stop the procedure with comparing three things actually. First, I will see the measurement of the fragment with my this laser tip. So the laser tip is around 200 micron. So if it is less than, the fragments are less than or comparable to that, then the fragments are very small. And second is I actually push some more force to the means the fragment to displace the fragment. So if it's readily get deflected from the calyx, then they are very small fragment. And if some fragments settle down, then I think that these fragments are bigger, and I'll go for dusting again this kind of fragment. And third thing, I'll go for the Siam clearance. Siam, ek baar dikhao na. Siam, I'll see the if it is can be seen in the Siam. If it is not, then our ऊपर थोड़ा सा इस तरफ आगे. So you can see the Siam is also, Siam view is also clear. So I think I will stop here and put a resistant here, and it will, all the fragment will come up. Yeah, Nitesh.
Make your life much easier.
What you are telling? Dust with suction? No, actually I don't prefer actually, because it always go for increase the intrapelvic pressure. There is chances of these things. I will minimize. Means this kind of dust will easily come out in 7 days, sir. Yes, sir. So I will come out, sir. Yes, sir.
I think these dusts are bigger in size than the volume in comparative to the volume.
No, sir. In Holmium, you will not find this kind of dust, sir. This golden dust you will see only in thulium, because see is a dust quality. This will not found in Holmium. If you get, if you can get that in Holmium also, but with very less energy and this thing, and it will take much time, sir, in Holmium to do that.
So this you can do like this also.
Okay, sir.
Keep the fiber.
Okay, sir. Put the stand and come out, sir.
Remain closer.
So we are finishing the case in OT2. Hello, am I audible?
Chance of response as
12 o'clock.
Sir?
So this in the floor, when you clear, so you can
Yes,
put
sir.
fiber like this. Then,
So-
there is no chance of going deep.
Question from here, research, what is the chances of scan stress?
Stone stress, sir.
Here, you can use like this also.
Stone fragments are when coming out, these things, stone stress, sir? Yes, sir. Yes, sir.
Question is, what is the chances of scan stress if you are
Stone stress.
lot of dust and leaving the system itself?
And,
The chances of the scan stress?
no, sir. Dust will come out, sir. But when we go for bigger stones, sir, when we go for, sir, more than 2 centimeter stones, sometimes we will do. We have done also. So in that kind of cases, you cannot do the RRS for more than 1 hour, 1.5 hour. We usually keep RRS below 30 minutes or 45 minutes. So at that time, when in a bigger stone, sir, when you fragments are stored in a bigger amount, more fragments are there, then this kind of possibilities are there. But in this dust, there is no possibility. I have not come across, sir, in my career till now.
You can include or you can just leave it like that.
Dr. Devaji, such a nice demonstration of RIRS. Thank you very much.
Thank you, sir.
And two generic questions about RIRS. What is your opinion regarding pre-stenting? Do you do it occasionally or routinely in your practice? And number two, if by chance in the start of your surgery you are not able to put the urinary access sheet properly, do you prefer to do RIRS even in that situation just by letting the scope over the guide wire?
Yes, sir.
Again, in this place,
Yes, sir. We actually do like that only. The answer of both question is my same only. So we does not put pre-stent. Actually, we always we ask the patient that always that there is a chance of may not possible to do the RS in the first process because then we have to do the stenting only. So in my career, 70% cases with this P7 ureteroscope or Flexex 2, we can negotiate in 70 to 80% cases. We can do in non-stented cases, and in 10 to 20% cases when it fails to put the ureteric access seat, then we do two things. First, we do the ureteroscopy once. Reason is two, because we have to see is there any ureteric stone or not, and second is if we are doing the ureteroscopy, then ureteric orifice will be dilated. Then also 10% possibility more chances you can put the ureteric access seat. Then also if not gone, then we actually we'll try with a seatless RIRS. We put the guide wire, and over the guide wire we try to negotiate it. But if it also fail, then we do the stenting and come out.
so done.
What were the chances of infection if you are not using the access seat?
So we try to limit our operative time when we don't use the ureteric access seat. Actually, we would limit to 15 to 20 minutes like that. And some fragments, if stay, then we will put a stent, and again during stent removal we'll go and do the fragment removal. And always chances are greater than when we put the ureteric access seat, because intrapelvic pressures are high when we do when we not put the ureteric access seat actually. So the chances will be, I think, in our practice, when we don't do ureteric access seat, the urinary infection, you will get around 30 to 40% like that. And if we do the ureteric access seat RRS, then the chances will be around 10% or less than 10%, sir. So in case we do the pure dusting, no sir, so we only do the X-ray KV only, and after 3 months we do the CT scan. And in case we have some doubt and bigger stone, then we'll ask the patient that there may be some fragment will be there, and do one CT scan after 1 month and come out. Then if fragments are there, then I will go and visit.
Hello,
Yes, sir.
am I audible?
Yeah.
So we are finishing RIRS, and we are also live on YouTube. If anybody wants to check, we are doing this surgery live on
Guided.
YouTube also. And The next case planned is TURP by our HOD sir,
Guided.
Dr. Rajesh Tiwari
Yes,
sir.
guided along.
Any more doubts on
Temporary
RIRS,
asset
or
for-
we'll discuss after the, like, which sir will be here in OT. By the time the patient is extubated, we can keep on discussing.
Dr. Devoli, there is a question from the audience. If you are not able to put the access sheet, you are not able to put the scope without the access sheet. In such situation, do you still remain adamant to do RIRS in a latter setting by doing dispensing there, or you choose other methods like PCNL or mini PCNL in that same setting? How do you counsel the patient in that setting?
Sir, actually, if we cannot do the aortic access, cannot put, then in 100% cases, we 100, I'll not say 100, in 99% patient we can put the aortic access sheet after putting the digestion, sir. After 2 to 3 weeks of putting the digestion, I will counsel the patient preoperatively like that only, sir. Yes, sir.
What size is 10 bore prefer larger bore 5 or 6 French or smaller bore 3 or 4 French?
Actually, sir, 5 French is enough. Actually, we need only ureteric dilatation. So, previously thought that we put a bigger digestion and then we'll have more size of the ureteric orifice. But I think in my practice it is never like that only. You can put 5 French digestion and it will be enough ureteric orifice dilation. What we need for RIS actually, sir. We have never done large size digestion if we fail fail to put the ureteric access sheet actually. So we have done only 5 French for digestion only.
So now the catheter has been removed, and first I will do the cystoscopy. Cystoscopy is must before doing TURP to rule out or to exclude other conditions because of which patient can present with acute retention of urine. It was the first episode. No, he should be given a warding trial. Ideally, he should be given a warding trial with on alpha blockers. Yes, tone is present and prostate is grade 2. Yes.
Although it is theoretical question, sir, 65 gram will come under grade 2 or 3, sir.
Borderline. 60 up to 60 it is.
Grade 2, sir.
Yes. So the purpose of cystoscopy is to evaluate the meatus and then the urethra and then the landmarks. So this is the veru, this is the sphincter, this is the veru, there are 2 lateral lobes kissing each other, and this is the raised bladder neck. This is the ureteric orifice on the right side, this is on the left side. Bladder is you can say that is mildly trabeculated. There is no other mucosal lesion. There is some slough or dirty tissue floating inside the bladder. Otherwise, This is the bladder neck, the two lateral lobes, and this is the veru. So while doing TRP, you have to limit your resection between the bladder neck and proximal to veru.
Good morning, sir. Sadaf here.
How? Yes, Sadaf.
Yes, sir. My question is, you have said that in every case, body trial should be given.
Yes.
But if there are absolute indications like, I'm not talking about refractory tension or upper tract changes, but if the patient is having recurrent UTI,
Yes.
or if the patient is having recurrent bleeding,
Yes.
eventually because of prostate,
Yes.
then should we go for body trial or should we go straight for TRP?
No, usually avoiding, there are two types of retention, even in acute retention. It may be a straightway acute retention, it may be acute on chronic retention. And there may be, because of sugar, there may be clot retention. So in clot retention, you can give wadding trial. In acute retention, because of, if it is not precipitated by some factors, such as exposure to cold or because of drugs sometimes, or sometimes infection even, then you should give a wadding trial with a course of antibiotics or alpha blockers. But if it is acute on chronic, I think there is not much role.
Why have you chosen the monopoly in that particular case?
Now that has been provided to us because by the in the OT. Here monopolar is only available. That's why I am doing monopolar. No, it can be HOLEP. It is also a good case for HOLEP. It is also a good case for bipolar. But as monopolar is still very popular, that's why I think monopolar is available there, or has been chosen for.
I think people's audience also want to see the monopolar only, sir. They want to learn. It's more interested because a lot of residents, many residents, junior persons are there, and surgeons.
But technique-wise, there is not much difference between monopolar and bipolar. But there are some advantages of bipolar. Less bleeding, you use saline, so less chances of TR syndrome. So you get enough time. Ideally, classical teaching is that you should restrict in monopolar to 60 minutes, but in bipolar you can. Pani? He was on catheter. Yeah, ideally, usually I do urethral calibration, 2 French greater than the outer sheath. But since he was already on catheter, so urethra is already dilated. That's why I have omitted the use of dilatation.
At this moment, what precautions you take to prevent the retrograde ejaculation and incontinence while starting the procedure now, sir? At this point of time, what precautions will be needed to prevent or to minimize the retrograde ejaculation as well as the urinary incontinence?
No. Incontinence and ejaculation, both are because of your ejaculation is 100% after TRP or any prostate surgery.
Sir, to reduce,
So,
what precautions?
so to reduce the incidence, there are some modifications are there.
Yes, sir.
You cut more proximal to the opening of the ejaculatory duct.
Okay.
So that the ejaculation, retrograde ejaculation is minimized. Another thing is you can preserve the bladder neck.
Yes, sir. So that I am saying that regarding the incision and the bladder neck,
Yes.
what precautions will be needed to reduce the retrograde ejaculation as well as the urinary incontinence? The incident of urinary incontinence.
And urinary incontinence is because of there are many types of post-operative incontinence. You have to specify what type of incontinence you want to prevent. stress urinary condition because of the sphincter weakness. So you have to, again, you have to respect the landmarks, that is Veru. You should not go beyond the Veru, and in that way you can prevent sphincteric weakness or sphincteric injury.
The incision inside the prosthetic tissue and the incision that will not extend up to the bladder neck, beyond the bladder neck, that having the certain impact on the inconvenience and retrograde ejaculation, sir?
In that, in this case, as I am entering the bladder, for नीचे कर दो, एकदम नीचे कर दो, एकदम नीचे कर दो, एकदम नीचे, एकदम नीचे. As I am, while doing TRP, one thing is very important for surgeons. जिनको लंबा रेस का घोड़ा बनना है, उनको अपने पहले पोस्चर पे ध्यान देना होगा. कैसे बैठे, आज ही हम लोगों ने योगा में सीखा है, स्पाइन सही होना चाहिए. स्क्रीन जो है वो आपके आई के लेवल पे होना चाहिए. और तो ये दो बात बहुत इंपॉर्टेंट है. स्टूल जो है कई बार हमने देखा है लोगों को, आई हैव सीन रेजिडेंट्स डूइंग TRP और स्पाइन इज आफ्टर बेंडिंग फॉरवर्ड्स, so that in that case spine gets painful, so you have to prevent your spine, neck. That is very important for here the bladder neck is, when I am keeping my scope at Veru, I am not able to see the bladder, so the bladder neck is raised. So in this case I will resect the bladder neck. So there are many methods of doing, techniques of doing TRP. BP is 113/66. It is the ideal BP for doing TRP. Around 120 systolic and around 80 diastolic. That is the ideal. And the cautery setting is, cutting is at 120 and coagulation is at 65.
Sir, we are shifting OT1. Dr. Padmakar is ready with lap pyeloplasty. Hello. Anshuman.
Good morning.
Shift to OT1.
Am I audible? Hello. आवाज आ
Hello.
रही है?
Hello.
अंदर से कुछ बोल रहा है.
Yes sir, I am listening.
Hello. Sir, we have shifted in OT1 and Dr. Padmakar is ready with lap pyeloplasty.
I am listening, sir.
External camera can.
External camera view and he is showing the position, patient position.
Oh.
So we are using today.
So blood vessels enter the prostatic gland at 5 o'clock.
Sir, today we are using. Yes, sir. Today we are using a 3D camera from Olympus, sir. So you are seeing all of us are wearing black goggles. Beautifully, all three of us are wearing black goggles. So 3D camera system we are using today from Olympus. Patient is a 28-year-old male who presented with right flank pain, and on ultrasound there was moderate hydronephrosis. We did an IVP. I have showed the IVP film in. If you can focus there. That's the IVP film. You can see. Right side, it's a typical case of right PUJO. DTPA shows 41% differential function, Tmax at 18 second, and there is GFR of 33 ml. So position of the patient is left lateral, as we can see, and not in absolute 90 degree. It's around 65 to 70 degree from the horizontal table, and there is no. I have not lifted anything. I have not put any bolster or anything. Patient also strap the patient. Patient is free. We have just put the support from the lateral side. So this is the position which only change when I am doing left side, what we do, the position is absolutely 90 degree, because there we need the weight of the spleen to fall back. So their position is little 90 degree. There also in pyeloplasty it's not required. For nephrectomy it's an absolute 90 degree. So first of all, I'll drape the case and then we'll start the surgery, sir.
Shift to OT1. Hello. OT1. Shift कर दो.
चलिए ड्रेप करिए, फटाफट करिए लाइव। ये जो है ना, हमको लगता है चिपकाने वाला है, पूरा खोलिए नहीं, हम कभी यूज़ नहीं किए, देखे भी।
And I always ask my residents to, after every cut, you should coagulate. You never know when your machine can go into failure, your corti can stop working. So, and if you go on cutting and not control the bleeding, then sometimes visions may ditch you. And whenever you are in doubt, always try to orient yourself with the landmarks. अंदाज से कुछ नहीं करना. Yes. It was very superficial abrasion only, and there was no difficulty in introducing the scope at any level. I didn't force it, so why to do more? Over treatment is also not good. Yes.
Even a small leech in glucosa will look like that you have lifted up. So this is absolutely magnified.
Yes. Yes. Pardon, I am not able to listen you. Please repeat your question. Yes. 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 You can do OIU, but sometimes we compromise, and if the gland is smaller, we do not use the outer sheath. Just with the help of inner sheath. In that case, we have to evacuate the bladder very frequently, or you can put a temporary SPC and do with the inner sheath resection and complete your resection. But never injured the urethra, because urethral stricture is a bigger problem than prostate. Yes, sir. Yes. Yes. Yes, yes, I agree with you that every effort shall be made to avoid stricture and metal stenosis.
One thing I must emphasize, see, not urinal calibration, it is the metal calibration which is most important.
Yes,
Because with the catheter there is an edema and you find this flexibility is lost. And if you put the receptors for 1 hour, there will be certainly ischemic severe metal stenosis. So to prevent that, if it is like that, you should do buniotomy, dorsal buniotomy, and you can avoid all those things. So metal calibration is important even if patients are catheter. Metal and sub-metal calibration is very important.
yes, sir, I agree with you.
So my question is related to pre-operating catheterization period. Today we talked about was taking that if you put a catheter for some days, pre-operating the urethra, and even I heard of talking one day, by the end of or he had also advocated to put a catheter for 2 days prior to URP, all about whatever. But the basic difference between ureter and ureter is a muscular organ. While if we put a degenerated muscle relax and ureter relaxes and this muscle procedure becomes easier. But in urethra it is a single layer in the medial structure which information is to allow. So by putting a catheter preoperatively for 2 days RP dilating the urethra or injuring the urethra and precipitating stricture. See, I have seen various of practice speaking about there are two. In fact, even in not sitting here, in Nadia they have a protocol. Even if the detection is because of BPS, they return to the catheter or solid catheter, or solution catheter. They used to do SPC. That is the better way. Another spectrum made to put the solid catheter even if it is not a so, currently to get the urethra, scientifically we don't agree with the second view. First, maybe any intervention with the urethra or catheterization, it is produced more infection than without catheterization. Yes, and the second one, how catheter is going to dilate urethra, it is beyond understanding. That because they have operated a wrong one, they have put and they have got their finger thinking. If they got their finger, they will realize that this is not a good thing. You have to be very scientific, think in a scientific way. That you are putting something from where the screw inside. And basically nothing can happen. All and any catheterization within 24 hours lead to polarization. And within 8 days there will be infection. It is 100% epidemiologically proved fact. So you are buying bacteria is not infection. No infection. If you have done other cases, I agree. But it's not scientific. Actually, what is the reason for dilatation? The whole ureter becomes paralyzed, right? Paralyzed, imperistaltic. So that is why it becomes very weak. And it is because of the paralysis. And in urethra it is otherwise. If you put any stimulation, there will be gripping there. And catheter versus SPC, I don't agree. Always try to put undersized catheter. That is very, very important. See, we have been practicing catheterization since long. There is no problem. Your catheter placement is limited. If you have used oversized catheter, all those happen. Otherwise, undersized catheter for bladder drainage is fairly.
Hello. So we are ready with the case pyeloplasty, and we are ready with the port positioning now. So, am I audible in the hall? Yes, sir. Sir, we are ready with the case pyeloplasty. I have made the surface marking. This is the subcostal margin, the rectus abdominis lateral border. and mostly the kidney will be somewhere here, and pelvis will lie somewhere here, just below the subcostal margin. So when we are planning our port positioning, there are three important things that we have to see. First is the manipulation angle. Instrument दीजिए, कोई भी instrument दीजिए. Manipulation angle between the two instrument. दूसरा एक और दीजिए. कोनो दीजिए. So it should always be 60 degree. So we should be manipulating the instruments at an angle of 60 degree. So this is important. Next factor is the elevation angle. So elevation angle is if we go very close to the target, that is the pelvis or renal hilum in nephrectomy, if we are very close, if our port is very lateral, our elevation angle will become, our hands will become like elevated. So that will be very uncomfortable for us to operate. So it should be comfortable. Ergonomically we should be comfortable. Shoulder should not shrug, it should fall down comfortably. So that elevation angle is important. Third important thing is how much instrument is outside and how much is inside. So our instrument length, this is the adult type, that is almost 36 centimeters. So it should be in the middle. So it should act like a type 2 liver, where the outside length and inside length is equal. In that, what happens when we move outside, equal movement is inside. If the lot of instrument is outside, a lot of movement from outside will replicate only small movement inside. And same goes reverse. If we are, a lot of instrument is inside the abdominal cavity, a very small movement outside will have a very large movement inside. So that will be difficult for the surgeon to operate. So port planning and placement is one of the most important step in laparoscopic surgery. Other thing is ergonomics, how we are standing, where we are standing. Our OT table should be at our waist length. It should not be, and it should, like this is not totally down. I am standing on a plank and it's not totally down. I can even reduce the height when I am suturing. That will give even more comfort to me while suturing if the OT table goes down. So now port planning. So if our pelvis is here, our camera should be in the same line in the of our target. So UPJ is our target. So our camera should be in the same line. That baseball diamond concept is there. Pen dekha, pen. So if this is the camera port, so it should be in the same line, and the two working ports should be at a distance where it makes around 60 degree. That is the manipulation angle. And the angle between the scope and the working instrument, that is the azimuth angle, it should be around 30 degree. So if these things are kept in mind, our surgery is comfortable and the entire procedure becomes comfortable. So how I plan when, see our costal margin is fixed, we can't go above that. That is the one landmark which we cannot cross. So in nephrectomy, our, Acha. So in our nephrectomy, the camera port is just below the costal margin. So I think sir has finished the case there. He will summarize. OT audio उधर शिफ्ट कर दीजिए. हम लोग हाँ पोर्ट बना. हाँ ठीक.
Sir, we have shifted.
Acha.
Hello.
Almost I have finished TRP. One important thing which I will like to highlight, that undermining of trigone one should avoid.
Syringe.
Because in the post-op period it can cause bladder neck contracture, it can cause in immediate post-op, it can cause bleeding and spasm, all sorts of things. So undermining is only done when you go and you keep the scope like this. If you keep the plane of the scope at your eye level or slightly elevated, the tip is elevated, then you will avoid undermining of the trigone. And I think it is complete now. This is the sphincter, this is the trigone, this is the bladder neck. This is the bladder neck. Thank you.
Very nice demonstration.
Thank you. I will show the stream and the color after doing a leak.
Their audio.
Yes.
But sir, the most common problem with the QRP is the post QRP section.
Yes.
What would you like to do to reduce this post QRP section?
As discussed earlier, that one has to use the smallest size urethral catheter for draining the urine in the post-URP period. Initially, we used to pass 24 French Foley's catheter 3-way. Now we are passing 20 French and at most 22 French. So that reduces the incidence. Another thing is to keep your resection time for as shorter as possible, not beyond 60 minutes. Third thing is, if the meatus is relatively small in comparison to your scope size, then you should do liberal meatotomy. And if the urethra is also small in relative to your scope, then you should do dilatation or urethrotomy before to reduce the incidence of stricture. Hello? So we keep traction for 4 to 5 hours. After 3 days, once the patient passes his stool and his urine is clear, then we remove it. But not before 48 hours. पानी खत्म हो गया क्या? निकाल के दिए इसको, इसको क्या निकाल दिए? पानी खोल दो जी, इसको बंद करो, इसी से भर लेंगे ना. लाओ एक प्रस्ताव. अच्छा, बराबर नहीं है. पानी भरते हैं उसको, फ्लो देखते हैं, निकालते हैं. हाँ, हो गया. बाद में कलर दिखा देंगे.
टेबल थोड़ा डाउन.
इसमें लग नहीं रहा है.
कैमरा पे डॉट.
हाँ, ठीक. हाँ.
हेलो.
कहाँ है कैलकुलेशन?
शिफ्ट करिए इधर.
तो नज़दीक कर दो.
Padmakar sir, you are on.
1 second. We are getting.
Hello, we have shifted in lab OT.
So we are getting accustomed with the 3D camera system. कैमरा को साफ करिए. गर्म पानी दीजिए. So port positioning is already done. I think the varus went into the retroperitoneum, so there is little bit of air in the retroperitoneum. That is going to help me only in dissection, so it won't be much of a problem. कैमरा क्लियर नहीं आ रहा है. कैमरा क्लियर नहीं आ रहा. गर्म पानी दो.
हाँ, आवाज नहीं आ रहा है.
Yes, sir. Sir, lap pyeloplasty, sir. Sir, sorry. Sir, so I have already insufflated, sir. I have placed my ports, and actually we are using a 3D camera, so we are getting used to the system. The varus needle went into the retroperitoneum, I think, sir. So there is, no, not less. There is air has gone into the retroperitoneum, sir. So it doesn't matter. It will help only in dissection, sir. Once we have to, while putting the varus needle, sir. Varus needle must have gone somewhere, and yes, sir.
So why not you look, or you prefer to put the open
Sir, sir, what I feel we have to use standard technique which we can use in all cases. Now, open technique we cannot use in, sir, very bulky patient or where the patient is very fat. So there it is very difficult to use open technique. So varus needle is a standard technique. Varus is little patients where the structures are very close, like this kind of problem can happen with varus needle. But it's a very standard technique and it can be used in all type of patient. So what I am using today is a sonic scission. होगा भी तो कोई अंतर नहीं पड़ता है. It won't matter. So sir, in the right hand what I am using is a sonic scission, sir. It's a handheld harmonic from Covidion. If everything is in the hand only, we don't have any generator or any machine. If you can focus outside, you can. दिख रहा है ना? इस पे कर दीजिए hand पे. हाँ. Can you see like this is the harmonic? Everything is in the hand only. We don't need anything extra. So I'll start the procedure. So what we'll do, we'll mobilize the colon first. I think we don't need to hold the kidney, liver up, as the space is all right. I think pelvis will be somewhere here down. नीचे दिखाइए sir. So we'll start mobilizing and then see if we need to retract the liver or not. Sir, yes, sir. In pyeloplasty, it's not always needed, sir. At times, the pelvis is quite lower down. As we can see the IVC here. Sir, thoda idhar dikhai. We can see IVC here, sir. And I think this would be the renal vein, this one, sir. So I think that would be our upper margin. So liver is falling and it's almost, I think we won't be needing much of a liver retraction. So if required, I'll put one more port and do the liver retraction later on, sir. Nephrectomy we place it, sir. Invariably it is required because, yes, sir. So, yes, sir. No, sir. Like the marking changes after we insufflate, sir. So we'll mark before the surgery, but normally go for the next bites. Again same thing, resetting, immediately hold the suture, hold it, pull it, and needle should never go out of the site. You should try to keep the needle in your site always. As IVC and very liver is there, anything can get lacerated. Yes, sir.
You always use the angled needle holder.
What, sir?
Needle holder.
Yes, sir.
Angled needle holder.
Yes, sir. I am more comfortable in angled one, sir. Right hand angled, I am more comfortable, and Maryland in one hand. Many people like they use both hand needle holders only or straight tip, and that is, sir, personal preference, sir. So resetting is very important. Like when we have to, if we leave the needle down, then again holding is a headache. Immediately we should again hold it so that time is not wasted, and I think holding the needle is initial struggle we face when we start suturing. So I think I have taken around 4-5 bites. So we'll take 1 or 2 more and then stent ready कर लीजिए. Sir, 12 centimeters. Sir. So how do I measure? I keep a measuring tape, sir. And that measuring tape, like once or twice I have done with that. And now I know from my hand length how much is 12 centimeters, sir.
So, you continue with your suturing. Can we shift to the other OT?
Yes, sir. Yes, sir. Why not, sir?
Will somebody from the OT present the case?
सर आप ब्रीफ कर देते ना सर जो आपको अच्छा अच्छा देयर सम टाइम इज देयर दे हैव जस्ट नाउ प्लेस द यूरेट्रिक कैथेटर इट विल टेक सम टाइम
Okay, they can till then they can give the patient particulars and the case history.
केस
So, show the images, X-ray, IVU, CT, whatever.
हाँ डाले हुए सर अपना वो दिए नहीं शशि भाई जस्ट सर का इंट्रोडक्शन दे देना I think posterior wall is enough. So now what we have to do, we need the suture or the knot to be outside. So how to do that? So we are inside right now. So what we'll do, we'll take one bite and now we are outside, we'll pull out the suture completely. So now we are outside, fine. So now the suture is outside. Now we'll take one last bite and we'll tie the knot outside.
Hello.
So we'll.
Hello.
Yes.
We are going to start other case by Dr. Rohit sir. Mini PCNL. Hello. Rohit sir.
बीच में लेते हैं
मार्कर है क्या?
हाँ.
Hello.
You are audible, please continue.
नीचे दिखाई नीचे.
Hello. Hello. Hello, audible? इधर नहीं आ रहा हेलो हेलो एम आई ऑडिबल देयर उधर से आवाज नहीं आ रहा हेलो आर यू एबल टू सी द प्लेन एक्सरे क्यूबी एंड आईवीपी एक आर्टरी फोर्सेट मिल जाएगा क्या so you are able to see the X-ray. I said now in X-ray actually there is some confusion is there. You can see very clear cut a big stone is there. But if you see carefully, two more stones are being seen. One here and one here. So it looks like this is a Calician stone and this is the infundibular stone. Like this is the infundibular stone and these are two Calician stones. Are you able to appreciate it? But on IVP, it doesn't look like that. It looks like only there is an infundibular stone and there is no Calician stone. It looks like only one infundibular stone is there and you can see a small calyx. So, I am not yet sure whether these are real stones or not, but it looks like that there is an infundibular stone and two Calician stones are there. Maybe these two calyxes are separate or the part of the same calyx. So problem with these stones are that when you puncture, if you go through calyx right from here, so it may not be always be possible to enter the last point, the lateral part. Maybe your puncture is bit medial. So what happens that you can clear this stone, but some stones may remain if you go through this, because the puncture may not be very lateral, it can be slightly medial, and then there will be a problem. So in such cases I generally tend to prefer coming from some other calyx. From maybe some calyx is here, I will try to come from here, clear this stone, and from this calyx through mini PCL I would like to clear it. This is my plan, but the final plan will be decided only at the RGP. Am I clear?
Yes, sir.
Because these stones are very problematic stones, these small stones. If your puncture is even slightly medial, you will miss this stone, and the post-op X-ray will keep on showing this stone, or even ultrasound will keep on showing the stone. So these small stones are problematic. It is always better to counsel the patient that these stones may remain and you may require a RARS or some other procedure later on. Even with RARS, this stone is very difficult to clear. So this is my initial idea before I really plan for puncture once the RGP is there. Okay? Okay. पलटो पलटो वो बॉस्टर लगा देना यार, ठीक है, जैसे हम लोग करते हैं ना वैसे ही करेंगे, क्योंकि इंफीरियर कैलिक्स है ना, उठा रहेगा तो दिक्कत करेगा। बॉस्टर है वो तकिया, हाँ ले आओ ले आओ ले आओ तकिया ले आओ, हाँ ऑफ कैसे, हाँ
दोनों का आवाज जो सेम है।
Can we switch the audio to
आई आई हाँ हेलो,
ऑडियो लेना चाहते हैं ले लेंगे।
there was a small, yes sir, there was small oozer from the pelvic wall sir, we have just buzzed it. Suction. Yes sir, yes. That only was spoiling the field little bit. So we have buzzed it, now we'll do small suction and then we'll place the stent now. Yes sir. At times sir, I almost sir 50 only sir. In this I would have even preferred 40, it was a little thicker pelvis sir. Length sir 12 centimeter always. I never go long sir. If we take longer suture sir, we'll struggle a lot inside sir. So we tend to save the suture and think that, but that is not good sir. So take a new suture sir, better, like you will not struggle sir. So we can see, we can see the evenly placed suture line sir, posterior line. We can see the ureteric opening, we'll apex, and now we'll put a stent now, and then apex पे एक और suture ले ही लेंगे यहाँ पे, stent डाल देते हैं, ठीक, suture लाइए और नहीं वो stent लाइए. So how we'll put up the stent? Camera इधर दिखाइए. So this is the setup that we use for putting stent. Is the suction cannula and the cystoscope, the what we say, the stopper or the rubber that comes with the cystoscope. We'll put it on that, and in the suction we'll place the this one pusher, and in the pusher the guide wire is placed, and from the above port we'll put एक मैरीलैंड इधर इस साइड आइए ना, घर कहाँ से नाच रहा है, हाँ इस साइड आ जाइए, स्टेंट ले लीजिए नज़दीक से गाइड वायर डालिए अंदर. नॉर्मली द गाइड वायर टेंड्स टू गो इजीली. पानी से फ्लश किए थे, डालिए डालिए, कोई बात पीछे करिए, थोड़ा पीछे लीजिए, हाँ अब डालिए हाँ ठीक. So now we can see the guide wire is going inside the ureter. So Foley is clamped था ना? Foley is clamped था कि नहीं? नहीं clamped था ना? चलिए इसको निकालिए. Great. एक बार काट देते हैं कंटिन्यू है, लेकिन उसका जो वो नहीं है
उधर से वॉइस आना चाहिए ना.
वाला काटेंगे, छोड़ देंगे. बहुत
हरी,
छोटा वाला,
उधर का वॉइस नहीं है.
बहुत छोटा है. ठीक, कंटिन्यू.
एक आखिरी फुर्सत नहीं मिलेगा क्या? सुनो सुनो, तुम निडल से डालो ना. जा रहा है ना. Am I audible?
Dr. Rohit sir is ready with mini.
Actually, in CM there is lot of gas shadow, so there is added problem. Can you show the CM picture? CM picture दिख रहा है क्या? ये stone लग रहा है और ये सारा they are all maybe other shadows are there. These are hostrations of the colon, but I am not sure what these shadows are. This is the stone. So what I was thinking that there are calcium stones here that I am not able to see on CT. One stone is there, but on X-ray I can very clearly see two calcium stones. But so we will proceed with the RGP. चलो दिखाओ. हाँ. बस सुनो. Is the RGP clearly seen? Most probably this is a posterior calyx because this is a lighter contrast, so maybe this is a posterior calyx, and this will also serve my purpose because I will come from above and maybe I will able to see the inferior calyx. 2 ml का syringe है क्या? 2 ml syringe है? 5 ml लो. देखिए छोड़ो. हाँ नहीं नहीं वो देखिए, पता नहीं वो सुनाई भी दे रहा है कि नहीं. I will also put air to exactly see where my posterior calyx is. So it looks like that is the posterior calyx, this area. Can I get a little? फिर से कंट्रास्ट डालो थोड़ा सा. हाँ फिर से कंट्रास्ट डालो. पंचर नीडल नहीं है, पंचर नीडल लाओ यार. अरे पीसेंट हुआ नहीं है क्या यार एकदम. पंचर नीडल नहीं है. This is the problem. I don't have a puncture needle. होगा होगा पंचर नीडल होगा यार. वो पद्माकर से पूछो, बताएगा पंचर नीडल आया होगा. ये मेरे साथ ना पहले भी हो रखा है पंचर नीडल.
इतना सारा लिया था उनको लगा कि ले लिया होगा, इतना हम नहीं
Yes
पंचर
sir.
नीडल नहीं है क्या?
Yes sir. Ah sir, that.
So this is a deeper one, so I will again make a adjustment.
What is the angle where we mount this Siam view and surface view?
चलो सर आरजीपी करो. Actually, the Siam view is not very good.
Actually, needle is not seen. This is guide rod type of things we are seeing that.
हाँ 20 करो. दिखाओ दिखाओ.
We are not seeing the guide.
0. दिखाओ. पानी मारो. पानी मारो. दिखाओ. दिखाओ. चलो दिखाओ. Actually, this is a PCNL demonstration is, I don't know whether you are able to see the puncture. Okay.
हमें बोलेंगे तभी
नहीं निडल नहीं दिख रहा है क्या इन लोगों का?
We are not seeing the needle.
हरी
It is hub. We are not seeing the hub as well as the tip of the needle.
नहीं, this is the hub.
Surface view and not CRV is not correlating. Zoom off.
Actually, the problem is that I am not able to see what you people are saying. There is no image here, so I am not able to appreciate. पर उनका देखो प्रॉब्लम क्या है.
Zoom off.
नहीं, zoom out what? Of Siam view or surface view?
Surface view, surface S is good. It's okay. It's fine now.
So, according to the initial plan, I am coming from the above calyx only. So, now we'll use a single step dilator of Castor's 16 French. ये
Siam view, please. Siam view.
16 है कि 18 है ये?
Siam view.
एक 16 सफेद
ये है 16.
हाँ ये है 16
और ये 18 है. हाँ चल 16 डालो. देख रहे हो ना पीसीएल इंस्टीट्यूट से बाहर नहीं कितना दिक्कत है. यस
We are not seeing the Siam view.
सियाम व्यू दिखाओ उनको.
सर
Siam view, please. Zoom out. Zoom out.
जूम आउट कीजिए.
आर यू एबल टू सी अ सियाम व्यू?
गॉज
Actually, at times dilatation is a problem. Okay. Now proceed. नीचे से ऐसे वो देना contrast. Yes.
Keep the vertebra always transverse during the puncture. Or
Yes. Yes. It is all. See, it doesn't make a difference whether it is transverse or vertical. It is just your orientation. Because this is the way I've been trained, so that's the way we do it. But if you are comfortable keeping it vertical, keep it vertical.
we usually do the, and Dr. Pal will usually always do the vertical. But in training, most of the centers in the south, they used to have the transverse vertical.
And that is the thing. Even during my training, also we have used this only. So I am continuing with that. But I do feel that it is just your perception. Doesn't make a difference. Actually, I am not very feeling comfortable with the dilatation. I still think I am not at the right place. Now it looks like yes. पानी मारना नीचे से. पानी मारो. पानी मारो.
I think also needs decreasing the zoom.
पानी मारो.
Zoom out. So that things are little more clear.
We are using a 16 French sheet and we will be using a Holmium laser by Alanzer.
The scope is of 12.5 French.
We are 12 French Castos, mini PCL. Actually in mini PCL this return is very important. This return should be clear. And if the return is bloody, then inside if I am struggling a lot, I will not persist with mini PCL, then I will convert into a standard PCNL. Because in mini PCL, bloody is a problem and at times the vision is really impaired. So this kind of return is very important. If the return is bloody, you go inside, there is lot of blood, no point sticking with mini PCL. Better to convert into a standard PCL and complete the procedure. But till now I am happy, the return is clear. So hopefully I will be able to see, have a good vision inside.
Where is the guide wire, the tip of the guide wire? That also has not.
Tip of the guide wire where? At the skin end or at the bladder end?
I mean
Actually, it has gone inside the ureter.
Oh, okay, okay.
Are you able to see that? If you see carefully, you can see it is going inside the ureter. पानी मारते रहो नीचे से.
So I've finished
It will get
suturing, sir.
clear.
Yes, sir. So 2 sutures I've used. You can see I've
So
kept
I
both
am
the
lucky
suture here.
the stone
So you can
has
see the
moved into
finished
the
product.
pelvis.
So this is the new
The stone
UPJ.
has
So
moved into
you can
the
see there
pelvis.
is no
I
tension,
generally
tension free.
remove the guide wire once I
Funnel
see
shape
the
it
stone.
dependent.
So I will remove the guide
And
wire.
yes, sir.
चलो आगे.
Thank you, and I think it needs a big
गाइड वायर निकालो.
quality of the surgery, but demonstrated the suturing technique.
सुनो ना, पानी पे तुम आ जाओ यार. ये शशि, तुम ग्लव्स पहन के पानी पे आ जाओ और लेजर फाइबर हमको 2 फुट दो. राइट में फ्रेगमेंटेशन है या डस्टिंग है?
Thank you, sir. Thank you, sir. And
राइट में
I
फ्रेगमेंटेशन
would like to
है या
thank
डस्टिंग है?
my team here, assisted by my senior Siddharth sir
नहीं, लेजर फाइबर
and Alam ji and anesthesia also. And I would like to specially thank
Left में
Ranjit
ये
sir
वाला.
for the lovely conference
पानी
that
का
he has
बाल्टी
organized
में.
and the best hospitality he has given to all of us here. So I think it was a great pleasure for me to operate in front of the stalwarts like Mahendra sir, Ranveer sir, and
स्टार्ट है लेजर.
all of my seniors. So now what about the drain, sir? Would you like me to put a drain or not?
यूसी थोड़ा पीछे खींच लेना.
Sir, I always put a drain. Small drain will not harm the patient.
यूसी थोड़ा पीछे
But
खींचो.
now they are saying that drain is not of much of a use. But I think it's not going to harm also. Good, yes, sir. It will give confidence if anything is there. So we'll put a drain and just we'll remove the 2 sutures. Yes, sir. We can shift the audio, sir.
Yes. I am using the fragmentation mode, 1 joule and 10 frequency, 10 watt energy. 1 joule and 10 is the frequency. Actually, my preference is to use less energy, because if you use more energy, there is lot of lateral movement. So better to give 30 minutes of extra time, but do it in a low energy so that the stone doesn't fly off here and there.
You are using the TFL?
No, holmium of Allenger, 30 watts. Just a minute, hold on. नीचे से पानी मारते रहो. इधर नीचे, हाँ रोशन आ जाए. छोड़ दो. हाँ, पानी मारो नीचे से. हाँ, लेजर.
I think it has come in the M+.
Yeah, but the problem is that it touches the sheath, so it doesn't come out. Each time you struggle, so better to break it. निकालो. Stand by. पानी मारते रहो. बस छोड़ो, पानी नहीं मारो. लेजर फाइबर. Actually, we have almost now shifted to laser as an energy source of stone. Okay. Stand by. No pressure irrigation. It is the normal irrigation. Irrigation is obviously on, but we are not using a normal pressure irrigation. It is a normal irrigation. And when I come out of the sheath, I prefer that somebody should flush from ureteric catheter. So, नीचे से पानी मारो. So I think this stone is clear here, and as I was suspecting, I will just go and inspect the inferior calyx. Maybe what I was suspecting was wrong, but better to see it. So this is the calyx where we are thinking there is a stone, but I am not able to see any stone. So there is only one stone, and during puncture that stone migrated to the pelvis, so our job became a bit easier. पानी मारना? No, so I am not able to see any stone in the inferior calyx. So most probably there is no stone in the inferior calyx, and there was a single stone that we have laced and cleared. Okay, I will confirm it on a CM, but CM picture is not very reliable because there is a lot of gas shadow, but I will still confirm it on a CM. देखो पानी. चल दिखाओ. CM view. So my first experience with Ellinger laser, that it is a good laser. I was bit skeptical, but it's a good laser. नहीं अच्छा लेजर है, बढ़िया. Yes. No, I don't put a nephrostomy. Generally, I put a nephrostomy if there is a pus, or I expect that I have to come again for the second time. Actually, I do prefer putting a DJ stent if I feel that some residual stone has remained, or there is a chances that some stone has fallen down in this ureter. But in this case, I think it was a very clear-cut case, so I will not put a DJ stent. And also on IITV image, I am not able to see any residual stone is there or not. एक बार फिर से expose करो. No, it is not tubeless. Ureteric catheter is there. It is not totally tubeless. So on IITV also, I am not able to see.
Dr. Rohit,
Yes.
it is a workshop. I think it is better to put this.
Okay, sir. Okay, sir. Okay. Okay, sir. हाँ नहीं वो दो लाल वाला इंट्रोड्यूसर और गाइड रॉड. इंट्रोड्यूसर दो.
कटा हुआ है.
नहीं फुल लेंथ ये लो ऐसे ही दो. हाँ ये इसके थ्रू डालो.
इधर से दीजिए, उधर से चढ़ाने में आसानी.
पानी बंद हो गया है.
पानी
नहीं इधर थोड़ा प्रेशर दो, थोड़ा खोले पेल्विस. दबाओ. हाँ हाँ बस उतना ही, उससे ज़्यादा नहीं. हाँ ज़्यादा नहीं, बस हो गया. डालते अरे वो यूरेटिक कैफर में जा रहा है. यूसी पीछे नहीं, निकाल लो. यूसी निकाल लो. हाँ नहीं रुको. उसको पीछे लो, रेड वाले पीछे लो. सियाम को ब्लैडर पे ले आइए. सियाम को ब्लैडर पे ले आइए. सियाम को ब्लैडर पे लाइए, दिखाइए. हाँ और अपने तरफ लीजिए, थोड़ा सा प्यूबिक सिम्फाइसिस को बीच में कीजिए. हाँ दिखाइए. हाँ चलो लो स्टैंड डालो.
उस साइड से डालिए, उस साइड से जाएगा.
नीचे आओ, सीएम दिखाओ ब्लैडर पे। हाँ ठीक, हाँ दिखाओ दिखाओ। हाँ गाइड वायर पीछे लो, दोनों को दिखाओ। लो पकड़ो, ऊपर आओ, दिखा दो। ठीक है। So I am not putting a PCN tube. So if everybody says that I should put a PCN tube, I will put. लगता है ऑडियो डिस्कनेक्ट हो गया। चलो बोलो।
चलेगा लेकिन डीजे
हाँ डीजे डाल दिए। चल बंद कर। वो डीजे तो अच्छा हमको लग रहा था। हाँ हाले खत्म। खत्म हो